Hey everybody, welcome back to This Week in Global Health, otherwise known as TWiGH, which is a regular video series discussing relevant and current topics in global health. In this episode, we're continuing our series featuring leading topics that have come out of the latest publications from the Disease Control Priorities Network, which is a publication that engages hundreds of health experts from a whole bunch of different areas to assess effectiveness, cost, and cost-effectiveness evidence for global health interventions in different disease areas. Now, today, we are going to be focusing on child and adolescent health and development. And this volume is featured by itself and can be found at the DCP3.org. I'm Jessica Taff, and I'm hosting this show today from Washington, D.C. With me to discuss today's topic, I have three experts on the issue.
I'm Don Bundy. I'm the lead editor of the volume we're talking about. I'm also a professor at the London School of Tropical Medicine and Hygiene, and previously I've been the lead health specialist at the World Bank. I've been an advisor to the Bill and Melinda Gates Foundation, and a professor at Oxford University. So I'm bringing a range of skills to this.
Hi everyone, my name is Elisabeta Aurino. I'm a development economist and I'm based at Imperial College Business School. I'm also research associate with the Oxford University and with the Partnership for Child Development, and I work on child and adolescent development, food security, and social protection.
Hi everybody, my name is Meena Fernandes and I'm also an economist, and I am presently based in Brussels, Belgium at a company called Milieu Limited. I was previously working at the Partnership for Child Development, which is based at Imperial College London. And that is where I focused a lot on looking at school health interventions in low and middle income countries. And previous to that, I was studying the same issue, but in high income countries. So this is an area of interest for me, is to look at differences across countries and opportunities to learn and from each other. Thanks.
This volume advocates that we need to focus on the 8,000 days after birth rather than just the first 1,000 that we're pretty familiar with focusing on. And there's been a lot of efforts into studying that and focusing our efforts. Why are we now saying that we need to focus on the 8,000 days after birth?
What we're saying in this volume, which is the first time that the disease control priorities volumes have looked at development as an issue rather than at looking at clinical practice, mortality, and public health areas. What we're saying there is that the first 1,000 days are indeed crucial for development, but the next 7,000 days are also crucial, and that the first 1,000 days is important but insufficient on its own, and that we need to be thinking through that whole 8,000 days that take you up to something around the 20th year of life. In other words, we're saying that the important investment for people to achieve their full potential is not just in those first 1,000 days, but right the way through to the 20s. I mean, it's what, of course, as societies, we've been saying for a long time, and I think what parents view also. But in terms of how we've invested in health and invested in education, we've not really so clearly said that before.
I know in this chapter, it's not just, a continual 8,000 days. You've actually split it into different stages. Could you briefly explain what those are?
So what we're really saying, the crucial thing we're saying is, let's not forget about children after they reach the age of 5. That, by the way, of course, is usually the time they start to go into education. But what we're saying here is, yeah, absolutely, we need primary and higher education, tertiary education, but we also, throughout that period, need investments in health. So let me give you, key examples of where we see as vulnerable periods. One would be puberty, and we're all well aware of massive change going on at puberty. That here's a phase in life when there are major behavior changes, there's major social changes, there's major changes associated with our gender recognition. And there's also, of course, just physical changes. And, one of the things that we really picked up on was that children at puberty, when they show this growth spurt, are growing as fast as they last did at the age of 2. So suddenly there's this really dramatic increase. And given that they're a lot bigger than 2-year-olds, there's a huge biomass change that happens at that time. Clearly, we need to think about how we invest in kids at that point. But let me give you another good example, which is late adolescent. So this is after the age of 15. There's a period, you know, we talk about adolescent behaviors, but what's clear now from the studies of brain development is there's an enormous amount of brain development that goes on at that period. And that's the time, for example, you know, when I was first taught about brain development, we had this idea that kids are born with their brains pretty well fully formed. That turns out not to be the case. And that in that period, this post 15 years of age period, what's happening is that there's a myelination, a thickening of the cells to make them transmit faster, so that the cells you already use get better. And then there's also this pruning of synapses, so less connection, so there's less false directions. So the brain gets really tidied up, if you like, in that period. And so that's the period when we establish behaviors, often a lifelong behaviors. And it's also the period when mental health issues first start to emerge. So again, a really important period in life. And intervening in the first 1,000 days is important in getting you on the right trajectory, but you've also got to intervene at those periods too.
Going back to, you know, children, the risk of death and illness in children under 5, this topic is widely appreciated. And what is new about this volume, and a lot of it you just mentioned, is that it brings new evidence of higher mortality estimates in children 5 to 19 than other of the previous estimates. I mean, a lot of what you were talking about were these vulnerable risk periods. But what you were saying is that, you know, there's also a lot of opportunity and risk for poor development or morbidity in other ways. However, the volume says that morbidity is poorly documented in this age group. That being said, what do we know about the health and development issues that children are vulnerable to this period and their long-term effects? I mean, maybe we just focus on the long-term effects.
So let me just say on that mortality finding. I mean, it's interesting how we were thinking about mortality in this age group. You know, we measure mortality in under 5 children, just like you said, Jessica, and we measure mortality in adults. And what we've been doing in the past is basically drawing a line between those 2 points and assuming that was reflected in what was happening. Well, we now know that's not true, and that the levels of mortality are higher than we thought they were in middle childhood. That's the period between 5 and 9-year-olds, and also to some extent in adolescence, so between 10 and 19. And what we also see is that the causes of mortality in the 5 to 9-year-old range are very similar to those for under 5-year-old children, and that the causes of mortality in the 10 to 19-year-old range are really quite different, with issues of violence, issues of accident in particular, and of course suicide also coming in as a factor there. So it's really a change. And you know, one of the questions one would ask oneself is why haven't we really picked up on this? And you know, actually one of the big findings in this volume is how much we've neglected children between 5 and 19 years of age. When I say we've neglected, I mean us. I mean we, the public health community. When we look at publications, we discover about 95% of publications in young people between 0 and 20. About 95% of those publications are in under 5s, and so only 5% of the publications are about kids between 5 and 19. And so, you know, we've really not paid enough attention, and that's also one of the big messages of this volume.
I would like to add to that point, Don, because there's a reason behind this. And I think one of the driving reasons is also highlighted in the volume is looking at the trends in mortality for under 5s over time. And we've seen a huge decrease over time. So it really made sense to focus on mortality, let's say 40 years ago, and before then. But we've had a lot of success in interventions to reduce mortality in this age group. So in a way, it makes sense. And now we have a lot of survivors. And now the question looking forward is, what about the survivors? What do we do with these children who are now, who have survived up to age 5 and looking forward? What about these children? What issues do they face? What is their potential, and how can we help them reach this potential?
I know that your area or one thing that you've focused on is food insecurity, and certainly this can have lasting effects when children are experiencing it, and their lasting effects in their lives. Could you speak a little more on that?
So first of all, from an education perspective, food security and nutrition are key, both in the early childhood years, because there is ample evidence that shows that early childhood nutrition affects children's capability to learn, cognition, even across the whole course. But in school-age children and adolescents, this is quite an understudied theme for the reasons that we were mentioning before. So actually, food insecurity and hunger can really affect children participation in their learning activities, because they cannot concentrate, they have higher feelings of irritability, children that are food insecurity at home are more at risk of being aggressive. So this really hampers their interactions with both peers and teachers, and really can affect in a negative way their learning. Meals can really help in supporting children nutrition over and beyond the first 1,000 days. For instance, we've done a lot of research in Ghana and Mali, in which we show that children that are in school feeding areas are more likely to be in school, to attend more often, and even to learn in a more effective way, especially the poorest children. So there are very complementary effects between nutrition and education.
And Bet, I'd like to get a little more into this. I mean, you use the example of nutrition, but a basic or a major theme in this volume really is the strong linkage between health and development and education, not just nutrition, though you've provided some examples of this. Could you explain a little more beyond nutrition, how the health and education are linked?
I think there are great synergies. And indeed, both education and health are fundamental dimensions of human development, and actually they are deeply intertwined, and investments in one area are obviously boosting the other area. So there are these kind of feedback loops. And I'll give you a few examples. So beyond nutrition, for instance, health interventions like deworming or tackling other infectious diseases such as malaria have been proven to foster attendance, because children are less sick and can go to school more often. And when they are in school, they are readier to enjoy the classroom and really learn. So there is a lot of evidence in that sense, but there is also a body of evidence that shows that educational intervention lead to better health behaviors over the life course. Things like healthier diets and smoking. There is plenty of evidence in high-income countries that show that, and I think there is scope also to improve the evidence base in these respects in low and middle-income countries. Another very important thing that we should mention is the role of girls' education, because there is evidence that shows that investing in girls' education is not only good for the girls themselves once they become adults, because they have better education, health, they are more empowered to do changes in their own communities, but also there is a very important intergenerational dimension. So there is plenty of evidence that shows that children that are born by higher educated mothers are less likely to be sick, to be better nourished, because, for instance, mothers can have better nutritional knowledge, and so about breastfeeding or healthy diets. And so they can become healthier and more educated in their life course. So there is a very important poverty reduction dimension that we should talk. And in this whole scenario, schools can really offer an important and cost-effective platform to scale up health intervention for school-age children in low and middle income countries. And this is particularly true in face of the huge expansion in education. So we are in the area in which we have the highest proportion historically of children that are attending primary school. And this happened like very fast in the past 20 years during the Millennium Development Goal area. So schools are pervasive, but most small villages have a school at least. They're more pervasive than health centers. And so they can really provide an infrastructure to do deworming, school feeding, and provide a whole set of health interventions.
You know, you've mentioned a lot of the various interventions that are going on and ways to support the health and development of children and adolescents. This volume has compiled an essential package of them. Could you explain some of the interventions that have been highlighted in this essential package at different stages of development?
First, I think it's important to go back to understand why it's important to define an essential package. There's a huge demand for this because there's an increasing recognition that there is a gap, that we do need to support the health and development of the school-age child. But it's not clear how to do this. There's a lot of evidence out there on different interventions, but it's not clear how these can go together, which interventions are really essential. So what we did, and this is very important for practitioners. So what we did is review what are the health needs in this population, and then we also looked at what interventions are out there and what is the evidence out there. And we've tried to identify interventions that were cost effective and that could be scalable, and that made sense in low and middle income countries. These are interventions that could go together and could be scaled up and be introduced in all public schools, for example, in a low income country. So we did this exercise. We reviewed all the academic literature out there. We reviewed many studies, and we ended up with 6 different interventions that went in the essential package for the school-age child. And one of this is school feeding. And these are meals provided to children in schools. We also included health education. And for this, we put a focus on oral health, as well as education regarding usage of insecticide-treated bed nets. This would be for malaria. We also included vision screening. Betha, you have a lot. I know you like to talk about this one, so I could pass it back to you for this. We also included 2 vaccines. One is the tetanus toxoid booster. Another is the HPV vaccine. And this one is targeted specifically to girls. And this would be altogether, these are 6 interventions. And we estimated the cost for this to be about $10 per child per year.
Now, I want to follow up on the cost of this, because particularly since education and the school feeding has to occur at a school, there's this intersectoral linkage, obviously, between these interventions, and that calls into question who pays for this.
So what we did here is establish what it will cost and what all these interventions will cost, but we don't go so much into who should foot that cost. But that really depends on the stage of development of a country. And the long-term goal is really that governments will take this on, that they see the value of this investment, and that it is reasonable, and it can be scaled up, and it can be integrated into the delivery of education already in the country. So this is a long-term vision. And the hope that is in the short term, and getting to that long-term vision, that donors and other players can come in and support. And it might be supporting in terms of finance. It might be support in terms of technical assistance. There's many different ways that support is needed. Countries may have the financial means to support this, but they don't have the technical know-how. And so it's really important to define what is needed, and then different players can come and help meet the gaps.
I think the example of school feeding is a great one, because school meals are obviously expensive, right? If you're giving somebody food every day,
Yes.
that's not cheap. So here's an example where we see 4 different sectors benefiting from this one intervention. So, people always imagine that you're feeding children for nutritional reasons, but that's probably one of the least clear reasons why you would be doing meals. But although that is a reason, if we look at education, providing food is remarkably good at getting young people into school, and particularly keeping girls in school. Also, school feeding is one of the best safety nets. In fact, most countries, that's why they do school feeding. It's one of the ways of making sure that really poor children actually get something directly. Funnily enough, in Britain, when Britain introduced its welfare system, the first thing it introduced was school feeding. So it was a social protection intervention, not a nutrition intervention. And then finally, and this is actually quite new and exciting, is agriculture. We've discovered now that school feeding in countries, if countries use homegrown food, homegrown school feeding, it actually is a great way of promoting local agriculture as well. So what that means is that when the Minister of Finance looks at school feeding, they're not just thinking, well, this is an education intervention, so it comes from an education budget. This is a budget that we can spread across different sectors.
Don, I'm really glad you gave those examples. And I know that you recently came back from South Africa, where you're saying there is actually a lot more support for linking health and education together.
I mean, the great story there, they have a program which they call Care and Support for Teaching and Learning. I like to think of it as care and support for teachers and learners. That's a big piece of it. And this is a program that actually really took off as part of the first 100 days of Nelson Mandela. It was his vision that really saw this as a way of addressing poverty and particularly inequity in poor children and poor people. And so now, they've been refining this program over a period of about 15 years. And it's a really effective program. I think the largest school feeding program in Africa is in South Africa. They're feeding 9.2 million children on a daily basis, right?
Wow.
So it's a remarkably successful program. And what are they asking about in terms of next steps? What are they considering is adolescence. So there's a program. It was targeted to help children in primary school. Now the move is towards secondary school. And the question is, how do you bring in these measures to deal with issues such as mental health and so forth?
One of the interesting things that I found was that, and maybe that's just silly that I didn't realize it, but children have different age and gender specific needs, meaning that boys and girls at age 7 or 11 are going to have different needs. The boys may need something at age 11 that the girls don't, or vice versa. And Beta, I know that one area that you're familiar with is the nutritional needs of adolescent girls. Could you talk about that?
So it's really critical to target interventions, nutritional intervention in this stage. And with regards to the gender differences, obviously girls, adolescence is the period in which there is the onset of menses, so the iron requirements increase. And there is a higher risk of anemia, especially in places where diets are monotonous because of food insecurity, poverty, and other structural determinants. And so it's very important to tailor interventions to these age-specific needs. The second point I would like to make relates also to gender norms that may kick in at this very, very specific stage of life. For instance, in my research using Indian data, I found that in adolescence, so at 15 years, there were stark inequalities emerging in the diets of boys and girls. And girls were systematically eating less nutritious foods, particularly animal source foods like eggs or milk or fruits. So these are food groups that are critical because are full of iron, as we mentioned, and other micronutrients and vitamins. So it's important to know that also gender norms may really affect the diets of adolescents. And the other thing I would like to mention related to this is about the pregnancy in adolescents. So there is a huge burden of teen pregnancies globally, and girls that are pregnant during this period are at higher risk of poor maternal health outcomes, for instance, anemia again, during the pregnancy. But also their children are at higher risk. For instance, there is higher chances of stillbirth or prematurity in the birth. And also children are born to adolescent mothers are also more likely to be stunted, which is an indicator of chronic malnutrition. And the other thing, and this relates to education, is the fact that teen pregnancies are one of the major causes for girls dropping out from school. So this suggests that we should really look at holistically at the various needs and also the kind of drivers of these poor nutritional outcomes, but also education and why girls drop out or get pregnant so early or get married so early.
Another interesting aspect of this topic really is looking into the future. And we're in a time where it's expected from a lot of different reasons, political, security issues that stem from natural disaster, political instability, etc., that we may have a lot of children in unstable circumstances that need humanitarian aid. And that certainly will affect their development, their health, not only while they're in that situation, but long term. And I wonder how we're considering this in the future, and how do we deliver these programs to them so that they do have a shot at developing as best as they can.
We know that both disaster like floods or droughts and human-made disaster like conflict have very long-term and intergenerational effects on child development. For instance, kids that experience war are less likely to have education, and this reflects on their income and productivity in the future. But we don't know much about how to mitigate these effects through social protection interventions that can really help, as you said, to make that this is not a lost generation. Okay. So I would like to bring up the example of school feeding. School feeding is a social protection intervention that is widely used in emergencies and other conflict or humanitarian settings. And recently, I worked on a paper evaluating a WFP emergency intervention of school feeding in Mali, together with some co-authors in Mali and other institutions. And we found that actually during the conflict, school feeding had a very protective effects on children education, with a particularly marked effect on girls' education, potential intervention that could help children support their health and education in these very challenging settings.
The chronic diseases and non-communicable diseases have, the burden of them has increased over the burden in a lot of ways of infectious diseases, particularly how they're affecting our health and different populations and the disparity between all of that. I wonder, Meena, could you talk about how non-communicable diseases and those chronic diseases affect children and how we need to think about their development with regard to that?
Historically, the main concern in low and middle income countries was infectious disease. And this is where the focus of policy was. Over time, we've seen an increasing burden of chronic disease. So there are issues emerging here. So one of the issues that has come up a lot in the academic literature is the nutrition transition. And basically, this means that rather than a focus so much on undernutrition, where there's not enough calories to consume, there's actually too much, and we're seeing an issue of even obesity emerging in countries. The projections looking forward project increasing levels of obesity in low-income countries. So this is an area of concern, and this volume is quite forward-looking and looking at in considering these trends. And so what has happened with the Essential Package is that we have some interventions that address chronic conditions and some that address some of the predominant infectious diseases that are still a major issue. For example, we have interventions such as deworming that are to tackle worms. And then we also have interventions like vision screening, which is about vision for children. So if children can't see, they can't learn. I would call this a more chronic condition. And then we have interventions like school feeding, which can serve to help meet the nutritional needs of children, help meet their caloric needs. But it can also ensure their dietary diversity, which is more an issue in contexts where you have higher obesity risk.
You've obviously made some recommendations in terms of the Essential Package interventions that should be implemented, context specific, of course. But where do we go on this topic from here?
We talked earlier about how there's been a lot of research done on the under fives and much less has been done for older children. And really here we see a need for longitudinal studies and collection of information. What is happening with these children? Collection of information about their health and their cognition, how they're growing, how it differs by high-income children, low-income children within the same country, differences by gender. There's a really strong need for this kind of information. And on a practitioner side, there's also a need to, we have the evidence, we know what needs to be done. And so there's a need to get it out and to scale up these interventions. So, and along with that, it's also important to monitor the delivery of these interventions and to ensure that they are being done and to seeing the impacts of them on health. So there's a need for evaluation to see what's happening and also to make them better. So we can release as much potential from these children as possible.
You know, we see a big change in the world. I think all of us have mentioned at some point the Millennium Development Goals, and those were terrific. They focused in education on primary schools, and in health they focused on mortality under 5. In other words, they focused on the very earliest stages of intervention, and they were terrifically successful actually in both of achieving their goal. Now with the SDGs, what are we saying? Well, we're talking about universal healthcare, and we're talking about universal access to education, primary and secondary. So suddenly we're saying, well, actually, we need to look after people throughout their lives. That's what we're now saying. We're now saying we're not just, the world has got to a place where we've really started to gear up in the early years. Now let's really think through, as it were, the 8,000 days and how is it we're going to deal with that. And the production of this book in the health area, volume 8 on child and adolescent health and development, the production of that in the health area has been followed up by the Global Partnership for Education, which has republished it as an education-focused version, so called Optimizing Educational Outcomes. In other words, it's what the I think very far-sighted leadership in the Global Partnership for Education are saying, well, this is okay, the health people will read this, but the education people need to know this too. So I think we are on the edge of a vision of human development that isn't just about health or just about education, but is really thinking holistically about what young people need.
That's a great way to end this. I want to say to our guests, Don, Meena, and Beta, thanks for chatting with us today. To our audience members, thanks for tuning in. Please, audience members, let us know what you think about this issue by commenting on our video or tweeting at us. We hope that you enjoyed this episode, and please check out more of our videos by subscribing to our YouTube channel, or you can check us out on our webpage, TWiGH.org, and you can find out more there. You can also find us on LinkedIn, Twitter, Facebook, Instagram, and we have a blog. For those of you that prefer to listen rather than watch, you're in luck because we actually have a purely audio podcast. You can check us out there. Find us out there on iTunes. That's it for today. See you next time. Bye.